So I will start now by introducing our guest today. Is Dr. Najib Ayas, and he's with the Department of Critical Care Medicine, and he's the head of the Department of Critical Care Medicine at the University of British Columbia. He graduated from the University of Alberta and completed his internal medicine residency at the Mayo Clinic in 1996, and he did postgraduate training both in respirology and in sleep and critical care medicine in Boston at the Brigham and Women's Hospital at the Harvard Medical School. He was on staff there for 2 years and completed a master's degree in public health from the Harvard School of Public Health in 2002. And we're very fortunate to have him join our group in September 2002 at Vancouver General Hospital, where he was appointed staff at the Vancouver Sleep Disorder Program. And in 2007, he was promoted to associate professor and also appointed to the head of the divisions of critical care medicine at UBC and at Providence Healthcare in 2009. So his research interests have been investigations of public health and safety consequences of sleep disorders, both sleep disorders such as sleep apnea and as well as sleep deprivation. And he's done some work with sleep deprivation among our house staff and residents. So that's important for you to know. You might have some questions about that, but he might not present tonight. But and he's received research funding from a number of national and provincial agencies and has also been very productive in publishing his work in respected medical journals. So I'd like you to give a warm round of applause to Dr. Ayas. Thank you.
Thanks. How many people here have sleep apnea or know of somebody with sleep apnea? Just to not put you on side. So actually a substantial number, okay? All right. So, the issue with sleep apnea is it's a disease that's not an uncommon disease. It's a very, very common one. And before I start, just for the sake of disclosure, I did receive some research funding from Respironics, but this was a number of years ago. And Respironics is one of the companies that makes CPAP equipment. But I didn't get any money personally, unfortunately, but they actually did fund some of my research texts. And basically what I'm going to talk about over the next half hour is basically what you need to know about untreated obstructive sleep apnea. Now, this was a picture from a Texas newspaper, and I think it said something in there about how this guy was falling asleep on the job or, was out partying or something like that as well. But when you look at this guy as a physician, you see him and you say, well, he's male, he's morbidly obese, he's profoundly sleepy during the daytime. There is a 100% chance this man has bad obstructive sleep apnea, and I would argue that he probably has not had a good night's sleep for many, many years. And basically what I'm going to do over the next 30 minutes is I'm going to try to answer the following questions for you and just give you an overview of the topic of sleep apnea. So the first thing I'm going to do is talk about what is obstructive sleep apnea. Okay? The second thing I'm going to talk about is what causes sleep apnea and what predisposes you to having sleep apnea. The third thing I'm going to talk about are the symptoms of sleep apnea that you should watch out for. The fourth thing I'm going to talk about are the potential health and safety consequences of untreated sleep apnea. The fifth thing I'm going to talk about is how do you diagnose patients with sleep apnea. And then the last thing I'm going to talk about are some of the treatment options available for somebody with sleep apnea. So when everybody goes to sleep at night, it's a time of relaxation, and that includes the muscles in the back of the throat. And so in most individuals, when they go to sleep, the throat gets a little bit more narrow because the throat relaxes, but most individuals are able to breathe okay. The problem you get into is if the throat relaxes a little bit more, then all of a sudden you're trying to push air through a very narrow tube. And this causes a lot of vibration and a lot of snoring. Now, the issue with snoring is that snoring, it's kind of a big deal for the people that you sleep with, but for you yourself as a health problem, it's not really that big of an issue at all. The problem that you get into is if the airway completely shuts, like in this case here, then all of a sudden you don't get enough oxygen, and your carbon dioxide level goes up, and you tend to wake yourself up a lot at night. So for instance here, this is a cross-section of a person. So this is the person's nose here, and this is his teeth, and this is his tongue. And you can see that when the person is awake, the person can breathe pretty well. When the person falls asleep, he loses tone in the upper airway, so that is in the tongue as well as the soft palate, and you can see it collapsing backwards. So that basically when the person tries to breathe in, he just can't breathe in because he's basically suffocating himself. Yes? Sure, sorry about that. Okay. And so what I'm going to do, so basically you can see here that this person cannot breathe at all, and he cannot get any air in through the airway. There's a couple of definitions that we have for sleep apnea. So if we say somebody has an apnea, what that basically means is when we monitor them in the lab, they just can't breathe for about 10 seconds, or at least 10 seconds. And this is what we would classify as an event. A hypopnea is where somebody can't breathe that much for 10 seconds, but still gets a little bit of air in, but not enough to really sustain themselves, so that either their oxygen level goes down or they actually wake themselves up, and this arousal from awakening actually results in the person being able to reestablish their upper airway and breathe. The severity of sleep apnea is basically classified by the number of apneas and the hypopneas per hour of sleep when we study them in the lab. Okay? So the reality is that everybody has got a little bit of instability of their breathing at night when they go to sleep. So anything between about 0 to 5 times per hour when we study people in the lab is actually considered pretty normal. Okay? So everybody, if I studied them in here, would probably not have 0 events per hour. They would actually have a few every hour. Between 5 and 15 times an hour, we consider that mild disease. Between 15 to 30, we consider that moderate disease. And if your airway narrows or shuts more than 30 times per hour, we would consider that in the realm of severe sleep apnea. And there actually is a spectrum of disease. Okay? So you have normal individuals who have a completely normal airway, and they go to sleep at night, and they're able to breathe fine and ventilate fine. Then you have individuals with a little bit of narrowing of the airway, so that when they go to sleep at night, it's a little bit narrowed, so that this air narrowing causes a lot of vibration and snoring. But again, as we talked about before, snoring by itself isn't really that big of an issue. And the reality is that snoring occurs in about 50% of individuals over about the age of 40 to 50. Sleep apnea, though, only occurs in about 5 to 10% of the population. So the thing to remember is that the vast majority of people who snore actually don't have sleep apnea. If the airway gets a little bit more narrow and starts to shut, you have what they call mild sleep apnea. And if it becomes more and more severe, you start to get into moderately severe sleep apnea or very profound degrees of sleep apnea as well. All right? And the issue is that people can go along this continuum, and the thing that really pushes people along this continuum is usually weight. So if people with mild sleep apnea gain a lot of weight, they can actually become more moderate or severe. And by the same token, if you have someone with mild or moderate sleep apnea, if they lose a lot of weight, they can actually go back to the side and be more normal or just have snoring. So again, just to summarize, so obstructive sleep apnea, it's a very common medical disorder. So if you actually randomly take everybody, and bring them into the lab and study them, about 5 to 10% of the population will have sleep apnea. And the prevalence of that is actually very similar to asthma. So asthma is about 6 to 7%, and diabetes is a little bit higher, but still in that kind of realm of 5 to 10%. So we're not talking about a real uncommon disease. This is a very common disease, and it's been shown by the fact that, when I asked everybody if they know someone with sleep apnea, most of the people in this room actually raised their hands. It's characterized by a recurrent collapse of the upper airway at night, and basically what happens is that you lose the upper airway tone, in the back of your throat, and then when you go to sleep, the airway closes and collapses, so you just can't breathe pretty well at night. Now, what's interesting is that the reason why that humans get sleep apnea but animals don't really get sleep apnea is because when the humans develop speech, the upper airway had to become very mobile to develop speech, And so because of that, you're able to talk, but the problem with that is when you go to sleep, you don't have a solid tube going from your mouth down into your lungs, and that's what collapses at night. So the first thing I talked about was what is obstructive sleep apnea. Then I'm going to talk about some of the causes or the predispositions for someone having sleep apnea. So by far the most important risk factor for obstructive sleep apnea is obesity. And unfortunately, as you can see from a variety of television programs, is that the rate of obesity has actually been increasing and increasing over the last 10 years. And what's really causes the disease is what they call central obesity or anything around the neck. So essentially, males with a neck circumference of over 17 inches or females with a neck circumference of females over 16 inches and males over 17 inches in circumference, they're actually at very high risk of having sleep apnea. And again, as we talked about, if people gain weight, then that will actually predispose them as well. Males actually have about 2 to 3 times the risk of sleep apnea as females. We're not really sure why that is. I think that part of it is structural in that the airway in males is a little bit different in terms of the size of the soft palate and the narrowing of the airway. There's probably some hormonal issues as well, and some people have argued and said that testosterone levels may have something to do with sleep apnea as well. What's interesting is that in women, the rate of sleep apnea is quite low until they hit menopause. So after menopause, the rate of sleep apnea actually goes up quite a bit. So it really suggests that some of these female hormones, such as estrogen or progesterone, may actually be protective of individuals. Now, why that is, we don't know, whether that has to do with deposition of fat in the neck or whether that has to do with the fact that it stimulates the upper airway. We don't really know. Increased age is definitely a risk factor for sleep apnea as well, and it's thought that as people age, they start to lose connective tissue, everywhere, I guess, including up in the upper airway as well. So the airway tends to get more floppy as people get older as well, and that obviously predisposes you to sleep apnea. Any kind of upper airway abnormalities would predispose you. So you can imagine that if you had really big tonsils, let's say in a child, okay, that would actually predispose you to having sleep apnea because there's just not enough room in that airway. And in fact, in children, the most common cause of sleep apnea would be enlarged tonsils, and the most common treatment in kids is actually to take the tonsils out. Now, unfortunately, in adults, it's not as simple as that, because in adults, most of the time, it's more related to obesity, as opposed to something really that can be fixable. Smoking has been shown to be a risk factor, and we think that that's probably because of edema and swelling of the upper airway, which again narrows the upper airway and predisposes it to collapse. Anything that relaxes the upper airway predisposes to sleep apnea as well. So if you take sedatives at night, that will predispose you to having sleep apnea. The big one is actually alcohol. And I don't know if anyone has had this experience where somebody will say, well, I don't really snore at all, but then if I have a few drinks, then I start to snore a lot. And the reason for that is that the alcohol relaxes the upper airway and narrows it at night, so that even though you might be okay if you don't take a few drinks, if you actually do take a few drinks, your snoring may get worse, and sometimes the sleep apnea may actually get worse as well. And there's a variety of other diseases that are associated with sleep apnea. So individuals with a low thyroid level, for some reason, they're actually at high risk of having sleep apnea as well. In fact, in a lot of patients who come in with sleep apnea, we will usually check their thyroid levels just to make sure they're okay. The next thing I'm going to talk about are some of the cardinal symptoms of sleep apnea. So again, what we talked about before was that loud snoring is basically the most common symptom of sleep apnea. But again, the thing that you have to remember is that about 50% of middle-aged people snore, but only about 5 to 10% have sleep apnea. So again, the vast majority of people who have loud snoring actually will not have substantial sleep apnea. Now, if a wife or a husband says that their spouse actually stops breathing at night or gasps and chokes, that's usually pretty indicative that they probably do have sleep apnea, and the major question at that point is just to try to figure out how bad the sleep apnea is. Now, if somebody doesn't have that, that doesn't necessarily mean that they don't have sleep apnea, because a lot of times your spouse may not, be, maybe a very sound sleeper, or let's say if people sleep by themselves, then people may never talk about their snoring or them gasping or choking at night. If people wake up in the middle of the night for unclear reasons, that's sometimes a symptom of sleep apnea. Because of the recurrent awakenings at night from the sleep apnea, a lot of people with bad sleep apnea will actually complain of daytime tiredness. So they'll wake up in the morning and feel like they haven't gotten a good night's sleep at all, and no matter how long they've slept, just feel like they haven't gotten a good night's sleep. All right? Gasping at night as well. Some people will complain that they wake up in the middle of the night sort of gasping and choking, and they're not really too sure why. Sometimes people will wake up in the middle of the night and have to go to the bathroom a lot. All right? Now, obviously, there's a lot of causes of that. But what can happen sometimes in patients with sleep apnea is they wake up because of the sleep apnea, but they don't really remember waking up from the sleep apnea. And then when they're awake, they just kind of think they have to go to the bathroom, but it really had nothing to do with going to the bathroom. It just had to do with the sleep apnea. In addition, it's been shown that people with bad sleep apnea, what can happen is their blood pressure tends to go up a lot at night, and their cardiac output tends to go up a lot at night, and they actually tend to put out more urine at night as well. So definitely there's a link between sleep apnea and going to the washroom at night or nocturia. The other one that people complain of are morning headaches. So sometimes people will complain that they have substantial headaches in the morning just because of the low oxygen levels at night, and that can definitely be a symptom of sleep apnea as well. The next thing I'm going to talk about are some of the health and safety consequences of untreated sleep apnea. And the issue you get into with sleep apnea is that probably about 80% of people with sleep apnea have actually not been diagnosed. So we're really only seeing the tip of the iceberg in terms of the number of people who have actually been diagnosed at this point. And this is what we think happens in people with sleep apnea. So you have individuals, they go to sleep at night, okay? Usually you can breathe, but patients with sleep apnea, they obstruct their airway, so they get an apnea where they actually can get no air in and no ventilation. What this causes is hypoxia or low oxygen levels in the blood. And in addition, because you're trying to breathe against your airway being obstructed, this puts a lot of stress on the heart as well, so that you get these very bad changes in pressure in your chest as well, which puts a lot of stress on your heart. In addition, because the body doesn't really like being in the state of being asphyxiated, what will happen is that the brain will actually wake itself up, so that they can start breathing again. Now, a lot of times the wake-ups that you get with sleep apnea are so short, that you may not even remember them, but it's basically like someone going in there and shaking you awake, 30 or 40 times per hour. What happens is when the person wakes up from sleep, they're able to breathe again, okay? But then when they go back to sleep, the cycle occurs again. So the airway obstructs again, the oxygen level goes down, they wake themselves up, and then they start to breathe, but then they go to sleep again, and then they have the obstruction again over and over and over throughout the night. So one of the things that happens is because you get these recurrent arousals or awakenings from sleep because of the sleep apnea, this results in very, very poor quality sleep. And with this poor quality sleep, this leads obviously to daytime sleepiness because, again, it's like someone going in there and shaking you awake many, many times, except you're doing it on your own. And in addition to that, you have a very much reduced vigilance as well. So it's very difficult to concentrate on things, and your mental status tends to go down as well. All right? What this does is this results in a reduced quality of life. It's been shown in multiple studies that patients with untreated sleep apnea have a substantially reduced quality of life compared to those who don't, especially in terms of like vitality or being able to function during the daytime. In addition, what's been shown is that individuals with untreated sleep apnea, they have anywhere from a 3 to 7 times increased risk of having a motor vehicle crash as well. So if you have somebody with untreated sleep apnea who's driving, they're at very, very high risk of having a motor vehicle crash also. The other thing that's been shown recently is that patients with untreated sleep apnea may also have an increased risk of occupational injuries, especially in terms of falls off scaffolding or construction or these things as well, which again isn't really surprising given how the disease acts. The other thing that happens well, and I think that there's been increasing data suggesting that sleep apnea may also cause premature cardiovascular disease or heart problems as well. So again, what we think happens is you go to sleep at night, and somebody with sleep apnea, the airway obstructs, so they get the apnea where they don't get any ventilation at all. They have low oxygen levels, and then they have a stress on their heart just because of these swings in pressure, because they're trying to breathe against basically an obstructed airway, and this causes arousals from sleep. The other thing that happens when the low oxygen levels is that it's basically almost you're activating your fight or flight response kind of thing. So you activate what they call your sympathetic nervous system. So it's basically, you're almost scaring your body into having a big response. So if you actually measure like blood pressure in patients with sleep apnea, it goes up by about 30 or 40% whenever you have an apnea. In addition, your heart rate will actually go up as well. In addition, it's thought that this recurrent low oxygen level, followed by oxygen coming on, this actually almost activates the inflammation in your body as well, especially in the vessel. So if you actually take people with sleep apnea and you measure sort of inflammation in their blood, it's actually much higher than patients without sleep apnea as well. In addition, the low oxygen levels also cause your blood to be very thick as well, which also may predispose you to heart problems. And in addition, it's been shown that patients with sleep apnea, because of all these derangements I talk about, they can have problems with their glucose being a little bit out of control and some other metabolic derangements as well. It's thought that all these things, the activation of the fight or flight nervous system and causing the high blood pressure and the shearing of the vessels, the inflammation, the thickening of the blood, all of this can result in atherosclerosis or cardiovascular disease and can also result in acute cardiovascular events as well. So specifically, myocardial infarctions or heart attacks as well as strokes as well as sort of the big one as well in patients with sleep apnea. Just an example, this was an interesting study that was published a few years ago where they basically took mice and they put them in a little chamber, and what they did was they made their oxygen levels very low for about 12 hours per day, trying to mimic patients with sleep apnea. And basically what they did was after they did autopsies on these mice, what they found was that 9 out of 10 of the mice in this sleep apnea model actually had really bad atherosclerosis, in the aorta when they opened them up. In addition, a lot of them had really bad inflammation in the liver and also had increased levels of cholesterol and these other things. And that was very different from the mice who actually got normal air. So in those normal mice, they actually did not have any of these cardiovascular abnormalities. This is a very oft-quoted, quite famous study that was published from Spain in 2005 by Jose Marin. And basically what these individuals did was they were trying to answer the question about whether patients with untreated sleep apnea are at risk of cardiovascular disease. So what they did was they took about 1,000 patients who came to their sleep apnea clinic and they divided them into 5 groups. The first were control patients. So these were patients who came in and didn't really have any sleep apnea at all. The next were snorers, so patients with snoring but no sleep apnea at all. Patients with mild sleep apnea, and then patients with severe untreated sleep apnea. And then those patients with sleep apnea that had gone on to CPAP therapy, which is one of the main therapies for sleep apnea. And they basically followed them over time for about 12 years or 144 months. And this is basically what happened to these individuals. So on the y-axis, you have the incidence of a fatal cardiovascular event. So that's where they went to the hospital and they had an MI or a stroke or something along those lines that basically killed them. Okay? And they saw how many of these occurred over time. And on the x-axis, you have time. So this is 36 months or 3 years. This is 144 months or 12 years. And this is basically what happened to these individuals. You can see that those patients with severe obstructive sleep apnea had a very markedly higher rate of these fatal cardiovascular events over a 12-year time period. What was interesting is that those individuals who had sleep apnea and that were being treated had a rate that wasn't really that much different in patients who did not have sleep apnea or who just snored without sleep apnea, really suggesting that the untreated sleep apnea were actually a very high-risk group. One of the other things they did in this study is they were able to what they call control for a variety of confounders. So what they did was they said, okay, well, we're going to take age out of the equation. We're going to take body mass index out of the equation, whether they took aspirin or all these things. And even after they controlled for all these things, those patients with sleep apnea had about triple the risk of having a fatal cardiovascular event over a 12-year time period. This is a graph from the same paper where they looked at non-fatal cardiovascular events. So again, individuals who came in with a heart attack or a stroke or something bad where it wasn't bad enough for them to die, but bad enough for them to come to the hospital. And again, you can see basically the same graph here. So on the y-axis, you have the risk of a non-fatal cardiovascular event, and on the x-axis, you see the number of months. So here, 72 months here, 144 months or 12 years. And again, you can see a markedly elevated rate of these events in patients with severe sleep apnea compared to those control subjects. And again, you can see that those patients who are treated in the blue line here didn't have a rate that was really that much different from that of controls. Again, suggesting, at least in this small study, that patients who are treated with sleep apnea do have a markedly reduced rate of events. All right. The next thing I'm going to talk about is how you diagnose patients with sleep apnea. So most physicians would be a bit uncomfortable about treating someone with sleep apnea without having a diagnostic test. And the reason for that is that about 50% of the time we're actually wrong. So that a lot of times we think the guy has sleep apnea, but he actually does not. Or we think that the woman does not have sleep apnea, and they actually do. So a lot of times it's very difficult to predict. In terms of how you verify the diagnosis, there's basically two major ways that we do it. One way to do it is at your home, okay? The second way to do it is where you actually come in overnight and sleep at the UBC hospital, and we basically, do wires on you, and we kind of completely look at your sleep, okay? The first one are these so-called home diagnostic systems, and they run anywhere from what they call an oximetry, where I don't know if anyone's had this, where they send you home with a little thing on your finger, okay, and it monitors your oxygen level for about 12 hours and sees what it shows. And then they have these so-called multi-channel systems, where instead of just the oxygen test, we actually give you other stuff to go home with, so it's actually kind of a better test to see, right? This would be sort of the simplest test that we would use to diagnose sleep apnea. So this is basically what they call a pulse oximeter, where it's attached to your hand, and it measures the oxygen level in your blood across the evening, and we can tell if it goes up or down. So the issue with this test is it's pretty easy to use, but it only gives you sort of one signal that you have. And this is the kind of tracing that I would look at if I actually sent someone home with one of these tests. So on the y-axis, you have the blood oxygen level. So this is 100%, which is the highest you can go. This is 90%, so we would expect most people to be above 90% throughout the night. And on the x-axis, you have time, and I think this is probably about 10 hours of some individual. And you can see this individual here, he starts out probably when he was awake about 98%, but you can see that he dips down very quickly here. And in fact, he dips down almost into the 70% range across the night. So if I actually saw a tracing like this, I would be very, very suspicious that this person has very bad, obstructive sleep apnea. So the advantages of this oxygen test is it's very easy to use. You just take it home, you put it on your finger. It's relatively cheap as a test because the test itself isn't very expensive. And I think that most people would argue that if you had someone that you really thought had sleep apnea and you just want something to verify the diagnosis, the oximetry would actually be a pretty good test for that. The problem with the oximetry is that you can sort of imagine that you're only getting one signal, on your finger, that if you had sort of milder degrees of sleep apnea, it probably wouldn't be able to detect it. And so basically, if you think that someone may have sleep apnea and you get a negative test, that doesn't exclude the diagnosis of sleep apnea. The other problem with the oximetry is it's very prone to artifacts. So if you actually move your hand a little bit, then the oxygen level goes down. There are other diseases that can make it be positive as well. So let's say in someone with what they call central sleep apnea from heart failure, or bad emphysema, or bad lung disease, or bad heart disease for other reasons, their oxygen levels can go down for those reasons as well. The other thing that you have to be careful of as well is that a lot of the oximetries that are done right now in the community, they're actually done by individuals who are trying to sell you the CPAP equipment as well. So one of the things that you have to kind of be careful of, because a lot of it depends on the technical quality of the oximeter, is you kind of want to know sort of who's giving you the test and sort of why they're giving it to you. So it's probably better to go to sort of more, a hospital-based lab, as opposed to relying on someone who's actually, in the market for selling machines as well. The other way that we do diagnose sleep apnea, and this is on the other end of the spectrum, from the simple oximetry, is what they call in-laboratory polysomnography or a sleep study. And basically what we do is we bring people into the UBC sleep lab. They come in about 8 o'clock at night, leave about 8:30 the next morning, and we basically wire them up from head to toe, and we measure everything that you can think of that has anything remotely to do with sleep. So for instance here, what we'll do is we'll put a bunch of EEGs on them, looking at their brain waves so we know exactly how much they sleep. We put bands around their chest and their abdomen to measure their airflow. What we do is we'll also put something under the nose to measure the air going in and out of the nose and the mouth. We measure their oxygen level as well. We put something along their chin to measure snoring, and we also put stuff on their legs to measure leg movements as well as chin tone and these other things as well. So it's a very, very comprehensive test. And this is an example of what I would see if I ordered a polysomnogram on someone. Okay? So on the y-axis, you have the variety of signals that we would measure, and on the x-axis, we have time. So this is 5 seconds here, and this is 30 seconds across this time period. And basically what you can see here, if we look at the EEG or the brainwave pattern, is this person is basically asleep right here. You can see if you look at the airflow, there's basically no airflow whatsoever for about 20 seconds. As a consequence of the no airflow, you can see that his oxygen saturation or his oxygen level goes from 90%, which is okay, down to about 70%, okay, which we would consider a very substantial amount of low oxygen level. Despite the fact that there's no airflow, you can see that he's trying to make effort. So this is a band around his chest that you can see keeps on going up and up and up. So even though there's no airflow at all, he's really trying to breathe, but because his airway is completely obstructed because of his tongue and his soft tissues, he just can't breathe at all. Eventually what happens is that the oxygen level becomes so low that the person basically wakes himself up from sleep. So as soon as the person wakes themselves up from sleep, they can breathe again, their oxygen level goes up. The problem you get into is when the person goes back to sleep again, you can see that the airway shuts again, okay, and then the person can't breathe at all, and this basically will continue over the course of the night as well. So the issue with the in-laboratory polysomnography is that the patient is supervised by a trained technician there the whole night. It's usually considered the gold standard to diagnose patients with sleep apnea. The major problem with this test is it's quite expensive to do, okay? So some people have argued and said that it's probably not justifiable to do it in every single person that you suspect of having sleep apnea, given that we think that 5 to 10% of the population we think has sleep apnea. And in addition, because it's relatively expensive, there's actually a relatively long wait time that you have for these tests. Now, where this test lies in relation to sort of other tests, we're not really too sure, and we're trying to work that out in terms of what would be the best test for every individual. But definitely, you know, if you weren't sure about the diagnosis, this would definitely give you that diagnosis. The other thing they've done is they've actually kind of said, okay, well, if we think the oximeter is not good enough, and this full sleep study might be, you know, almost too good, you know, is there something that you can do in between? And so in the last few years, they've come out with these multi-channel ambulatory devices. So it's basically similar to the oximeter that you would send people home with, but in addition to the oximeter, you have a variety of other signals as well. So you usually put something under their nose just to measure what their airflow is, and something along their chest and measure their oxygen level as well. And it's thought that even though it's not as comprehensive as the in-laboratory sleep study, it gives you enough extra information that you should be able to make the diagnosis in something that you thought had it. And again, I'm not trying to market any specific device because there's a bunch of them on the market, but these are things like the WatchPad or the SnoreSat or Night Watch, Stardust. There's a whole bunch of these things on the market. This is an example of the so-called Stardust machine. So again, this is a device that you go home with, and you can see here that the person has something under his nose to measure airflow. You can see he's got a band around his chest to measure his respiratory movements. You can see a little wire here, you know, on his finger to measure his oxygen level as well. And it's thought that this might give you a better signal than just giving that oxygen level on the finger. This is an example of what I would see if I ordered this test, okay, in the lab. So again, on the y-axis, you have the various signals that we're recording. So this is the oxygen level or the saturation. This is the flow that's coming in and out of the person's nose. This is the effort that's measured by the band around his chest. This is the snore signal that's measured as sort of a vibration signal. And then this is just the position about whether he's on his back or on his side. And basically you can see here that if you look at the oxygen level, sometimes it's 93, sometimes it's 83. So you can see this sawtooth type pattern of this oxygen level. So as soon as I see that, that would really be suggestive there's really something going on with this person, that he's having low oxygen levels, probably from sleep apnea. This represents the airflow, and you can see here that there are episodes here where there's actually no airflow whatsoever, despite the fact that the person is trying to breathe. So again, this would be pathognomonic of somebody with bad obstructive sleep apnea. So again, if I saw something like this in the right clinical context, I would say this person has very severe obstructive sleep apnea and would require treatment. Okay. So now that sleep apnea has been diagnosed, the next question is, well, what are the treatment options for sleep apnea? All right. The first thing that we always do is sort of behavioral lifestyle measures. So definitely, as we talked about before, if you gain weight, okay, and weight in general is a risk factor for sleep apnea, If people lose weight, their sleep apnea will usually get better. Now, in an individual person, it's difficult to predict. So I've seen some individuals lose 20 pounds of weight, and they go from having severe sleep apnea to having no sleep apnea. I've seen some people lose like 80 pounds of weight, and their sleep apnea is exactly the same. So in an individual person, it's difficult to say, but in general, it seems that the weight loss does reduce the sleep apnea. In addition, we usually tell people to avoid alcohol and sedatives, especially within 3 to 4 hours of bedtime. And we do tell people to stop smoking, not only for the sleep apnea, but for, it's obviously good for your health in general. Now, for patients with milder disease, especially if they're not that sleepy or symptomatic, that's usually enough to kind of take care of things. But in individuals with more substantial disease, or if they have symptomatic sleepiness, the other thing that we would usually do is either do some kind of medical or some kind of surgical management for these patients. The first medical management is what they call positive airway pressure therapy, or CPAP therapy, and the second are these so-called dental appliances. In terms of surgery, they fall into two categories. One is where you actually try to modify the upper airway, try to surgically change the structure of the airway. And the second is to treat the obesity. So in individuals who are morbidly obese, if you actually send them for some kind of bariatric surgery to reduce their weight, that may reduce their sleep apnea. And what I'm going to do is I'm going to go through some of these in more detail. Okay? So continuous positive airway pressure, or CPAP. Again, anyone here on CPAP or know of somebody on CPAP at all? Yeah, so again, it's pretty common, So continuous positive airway pressure, I think last time I checked that they estimate that about 2 million people in North America are currently using CPAP, at this point. So very common, right? So continuous positive airway pressure, it's usually the first-line therapy for substantial degrees of sleep apnea. And basically, the CPAP machine consists of a flow generator that's attached to a nasal mask and then some plastic tubing as well as headgear, okay? So it's got to be an airtight mask in order to give the pressure. And this is basically what happens when we give people this positive airway pressure. So this is the normal airway here, and you can see that this person has bad obstructive sleep apnea, and his tongue is going back and obstructing his airway. You can see his soft palate obstructs it as well. This is what happens when you put this CPAP machine on. What happens is it takes air from the room, and what it does is it pushes the air in under pressure. So it's basically like a reverse vacuum cleaner almost. In fact, the original devices that were made were actually modifications of a vacuum engine. But basically what it does, instead of sucking the air in like a vacuum cleaner, what it does is it pushes the air out and pushes the air out under pressure. By pushing the air out under pressure, it's just basically like blowing a tube open. Okay, so if you put enough pressure on a tube, it will open up, and that's what this CPAP machine does. It will actually open up this airway. So the issue with CPAP is it's been shown to be fairly effective in terms of improving oxygen level, improving sleepiness, probably improving cardiovascular disease, and the physiology of sleep apnea. The major problem that we have in CPAP, as you can kind of imagine, is more the compliance with CPAP, because a lot of people don't really like sleeping at night with this big machine and stuff on their face. So on average, the compliance is usually anywhere from about 75 down to about 60%, depending on what population that you look at. Now again, some people really like the CPAP machine and feel that it's changed their lives and everything, but there are a substantial proportion who, for whatever reason, just can't use the device or can't tolerate the device. In the last few years, the technology for CPAP has actually gotten much better, So especially in terms of improving the mask interface, has improved substantially over time. And at this point, there's basically like 100 different masks, on the market around to fix, basically fit any kind of facial structure that you can think of. In addition, they make these chin straps so that it keeps your mouth closed. The other thing that helps with CPAP compliance is humidification. So it's been shown a few years ago that if you actually added a heated humidifier to individuals, that will actually substantially improve their compliance and their experience with the CPAP. And in addition, in the last few years, the companies have come up with a variety of variations in how they deliver the pressure. So before it used to be kind of a constant pressure, and one of the things that people complained about is when they breathed out, they felt like they were suffocating because the pressure would keep on pushing air in while they were trying to breathe out. So some of the newer machines now, they'll actually drop the pressure, when the person tries to breathe out so that they can breathe out. Some of them will actually change the pressure with inspiration and expiration. There's these smart machines now on the market where the pressure will go up and down across the night to actually match your sleep apnea with the pressure as well. There are some individuals, though, for whatever reason, because of social issues or they just can't tolerate the CPAP, who need to go to something else. The best therapy is probably what they call a dental appliance or an oral appliance. And basically what you do with this is that you have a mouthpiece that's attached to the upper and the lower jaw. Like, I don't know if anyone's got a mouthpiece for teeth grinding, where you stick it into the top jaw. Well, this one actually is kind of like that, except you stick it into the top and the bottom. And because your upper jaw is fairly fixed and your lower jaw is what moves around, if you can basically splint your upper jaw to your lower jaw, you can actually pull it forward, and open up the airway here so you can breathe a bit better, all right? Now, the issue with these dental appliances is that they're not as effective as CPAP overall, because the thing about CPAP is I can keep on increasing the pressure until I can fix your sleep apnea. But with these dental appliances, I can only pull your jaw so far forward before you just can't pull it forward anymore, okay? So I think that across the board, it works in about 50% of patients with sleep apnea. The kind of patients that it seems to work best for are usually it works better in thinner patients as opposed to more obese patients. It tends to work in patients with less severe disease, and it tends to work in patients with kind of a big overbite as well. So if you kind of saw the guy who's got this really small jaw, with this really big overbite, that's somebody that I would really think about a dental appliance, because if I could figure that if I pull the guy's jaw forward, that could probably fix his sleep apnea. The other option is surgery for sleep apnea, and I would argue that, I've sent a very, very few of my patients for surgery for sleep apnea. Usually the surgery for sleep apnea has to do with just taking out as much redundant tissue or soft tissue in the back of the throat. So it's usually taking out part of the soft palate and the uvula here. Sometimes what they'll do is they'll try to ablate part of the tongue as well to try to get the tongue to be a little bit smaller, to try to open up that airway and to basically sew up your tonsillar pillars right here and here. Overall, the surgery across the board is probably about 30 to 40% effective, and it usually loses its effectiveness over time as well. So the only times that I've really sent people for surgery is usually in patients with fairly mild disease, and usually kind of in younger men who don't want to use CPAP more for social reasons, and for whatever reason can't tolerate a dental appliance or want to do something different. Now again, sometimes I've sent it if and nothing else works, but again, usually if nothing else works, then usually surgery isn't really that great of an option. The other thing in terms of surgery is actually bariatric surgery. So it's been shown that individuals who get bariatric surgery, and lose like 150 pounds for the bariatric surgery, in a lot of them, their sleep apnea will actually get a lot better, if they're able to lose that type of weight. So anyways, just to summarize for the last 30, 35 minutes, the first point I want to make is obstructive sleep apnea is common. You're talking about 5 to 10% of randomly selected men and women, and it's underdiagnosed, so probably about 20% of individuals at this point have been diagnosed, and probably about 80% of individuals actually have not been clinically diagnosed. Character symptoms include loud snoring. Well, the thing to remember is a lot of people snore and don't have sleep apnea, so that by itself may not really push me one way or the other. But things like gasping at night, daytime tiredness, morning headaches would really push me to kind of thinking that the patient does have sleep apnea, especially if the person had a lot of these other risk factors, such as obesity or increased age. Risk factors include male gender, obesity, smoking, and alcohol. There are a variety of adverse safety and health effects. So the safety effects are more from lack of vigilance and tiredness. So things like motor vehicle crashes, occupational injuries, poor work productivity. And in terms of health effects, there's increasing data suggesting that this is an independent risk factor for cardiovascular disease as well. So thank you very much. I guess I'll open it up for questions.